Well, I'm Dr. David Johnson, Professor of Medicine and Chief of Gastroenterology at Eastern Virginia Medical School in Norfolk, Virginia, and welcome back to another Computer Connect. Well, Barrett's esophagus screening, one and done. That's the way I've always practiced in the absence of patients that maybe have had erosive esophagitis, and we need to go back and make sure that there's nothing sometimes hidden under the erosive change. And that's in fact what the most recent iteration of the American College of Gastroenterology guidelines says, that Barrett's screening should really be done and restricted to chronic GERD patients with 3 or more of the following risk factors: over the age of 50, Caucasian, male, smokers, obesity, and or first degree relative of Barrett's esophagus and or esophageal adenocarcinoma. Well, the tradition is that they don't need to be repeated, and that's what that guideline says as well. But what if they develop Barrett's after that initial screening is done? In fact, we've seen some data from previous studies, the Pro-GERD study done reported in 2006, looking at the 2-year follow-up of patients of nearly 6,000 patients done in Australia, Switzerland, and Germany. They looked at the incidence of Barrett's esophagus in patients with non-erosive disease. They found 0.5% at 2 years, and then reported the data out again in 2012 at 5 years and found 4.2% of people now had, quote, incident Barrett's esophagus. Well, we do have at least some data that Barrett's may develop in early to middle adulthood. So again, if the screening was done too early, a one-time endoscopy may not be quite as effective in prevention. And that's something that was evaluated in a cost modeling study, very interesting and well-designed study, again, by Dr. Joel Rubinstein and his colleagues. They looked at a cost-effective analysis looking at 3 simulation models and found in patients with chronic GERD symptoms that restricting the modeling suggested that a repeat endoscopy from age 45 to age 60 in a Caucasian male actually had a prevention of adenocarcinoma of the esophagus in 23% and associated death from adenocarcinoma of the esophagus in 30% of patients. Using that strategy, they found that a repeat endoscopy from age 45 to now at 60, the best optimal strategy. They found that it was not cost effective in women, and in fact it may cause harm in Black women. So again, cost modeling suggesting a repeat endoscopy certainly raises the entry into the most recent discussion for today. And this is a study that looked at the yield of a repeat endoscopy of Barrett's esophagus after a normal index endoscopy. This was a national retrospective analysis, again led by Dr. Joel Rubinstein and his colleagues, within a U.S. Veterans Administration database. They took some 71,000 individuals who had an endoscopy and a repeat, and the patients had an index exam all before the age of 70. And then they had a repeat exam within a period of 1 and 16 years after their index endoscopy. And then they looked at ICD-9 codes to look at new diagnoses of either Barrett's esophagus, adenocarcinoma of the esophagus, or adenocarcinoma of the EG junction. What they found was very interesting because the duration between an endoscopy and time from the interval endoscopy to the repeat, for every 5 years, the adjusted odds ratios increased for a new diagnosis of this Barrett's or adenocarcinomas at 1.3 for the adjusted odds ratios. In fact, they saw the development of Barrett's esophagus or overall all these diagnoses in 5.7%. 97% of these were Barrett's esophagus, 2% were adenocarcinoma of the esophagus, and 1% of the EG junction. I was intrigued that in this they found about 53% were short segment, that is less than 3 centimeters. Very interesting that 22% were actually long segment. The longest segment was up to 13 centimeters. Amazing that this could have been missed on an index exam. But nonetheless, there was an incremental yield as it relates to the durability of the index exam over time and a repeat subsequently. There were increases as well noted for the other individual risk factors that we talked about: Caucasian male, patients that had smoking history, obesity, or first-degree relatives with Barrett's or adenocarcinoma. But in fact, if they had an index exam between the age of 19 and 29, their adjusted odds ratios for these developments were nearly 4 times greater. And in comparison, if you looked at the patient that had an index exam at age 19 to 29 compared to an index exam at 65, it was 7 times greater. So back up, one and done? Maybe not. Certainly, I would consider this discussion added into your patients at risk, when they had their exam, what the other risk factors were, And it certainly needs to be discussed in a modeling strategy. I think there is strong evidence at least suggesting that this may be valuable in those patients with defined risk. Even the authors of the current study do not recommend altering clinical guidelines based on this, but I think it gives time for pause and provocative change of maybe what we have ascribed to as tradition. Maybe new evidence suggests that maybe it'd be modifiable to change. We certainly change our intervals for colon cancer screening. Age has moved up to 45, and maybe we should be doing a little bit differently with our Barrett's and our follow-up of Barrett's in patients defined at risk. At least think about it. I certainly will. Dr. David Johnson, thanks again for listening.